going.
Oh, I'm sorry. Sorry, Chief. Anyway, pass these out to one or two cards,
Okay.
and I guess you'll take pens, right? Okay, busy. That ain't working. All right, cold out there.
It sure is. Real windy.
Too cold. You wash those things?
I should spray them with Lysol.
Spray them with Lysol?
They haven't been used.
Who?
That?
No, she's not going to be here this evening. Yeah.
I wonder if there was any advertising. Yes. All these flyers and stuff? Yeah, but they were handed out. How about Barry? Do emails?
Well, I hope so. That's where we get most of the people.
Yeah.
Yes.
Yeah.
Even when the newspapers do put it in, people get it through the email.
Uh-huh.
But I made sure that these circulars, I made tons of copies. I mean, like 100 copies.
Really?
They were distributed to the different schools and stuff.
Wow.
Yeah, I always do that. So they're out there.
I have to put the number in every time I hit redial.
Been here before? Nope. No? You have to sign in, give us your name, and if you would like to give us your address or email.
Hi, Barry. This is Ed Barnes. How you doing? Ed Barnes.
What? Oh, this is where we're at.
Yes.
Okay.
Forgotten about it, or? Oh, yeah. You don't have to come now. You know, it's too late. Did you send out the cards or anything? Okay. That's okay. I sent you an email, but I guess you didn't get a chance to check it. Monday, I guess it was.
It's how prints on the internet.
Okay, well, we'll just do what we gotta do.
Oh, really?
It's the doctor's file.
I'm curious to, we'll just go do New York for
We'll beat you up at the next meeting. Yeah,
They
sure, it was advertised too.
Phone number.
Sorry.
I said, did you get the QE?
So, no car flying out, no
Just a little bit. Just a little.
Did you get married?
Yeah, you forgot.
Everything?
Mm-hmm.
We'll both find out tonight.
This particular neurologist has a philosophy about measure.
This interesting? Why is this interesting? I can see.
I thought that's what Amanda did. I didn't think anybody could. Show me another trick.
How long did it take you to get here?
A good 45 minutes.
Sometimes the traffic, it's been nasty.
Yeah, well, we had dinner in Wilmington and came over that letter. Anticipate.
God, they weren't sent out. That's terrible.
You don't have to sign in now. You just introduced yourself, so that's fine. Thanks.
Nice weather. This is Dr. Hill.
Elaine's from left. Hi. Nice to meet you. Your hands are.
Here for their panel. Is Linda coming?
Yeah, she'll be here. She had a client till like 7.
Jamie's sick today. So I was home all day with her.
We could just start it.
Everybody has
That's one reason why they're not working, because if you're dopamine deficient, you should be treating that. And if you're serotonin deficient, instead of just giving you a pill for the symptoms that you have.
Well, no, the pill is correcting that.
That's what the pill does. Right.
It is creating more.
Correct.
It's balancing the,
What, are you in charge tonight?
fire.
Well, a little bit. A little bit. We just had a client saying that the guy that, what's the matter? You okay?
I remember that. I'm back. Not real, but it was a pain.
The guy that sends out the invitations, everybody to remind them, forgot to send them out. So we have ads, out in the local papers and things like that, so the turnouts from the day, so.
Patient's not affected.
Some people are very hypersensitive to it, and you have to look at alternative methods.
Well, that's my deal.
Right.
Now, vitamins and stuff like that work pretty well, but when I exercise and stuff like that, it doesn't take away the symptoms.
Absolutely.
But I go into panic in the summertime. I'm a teacher. I go into panic in the summertime when I have 10 years off with nothing to do. I mean, I go into a panic.
Oh, did she talk to you lately? She said she was
Yeah, I've been talking to her in about a month, I guess it's been.
She's doing really well.
Yeah, last time I talked to her, she was going for a job at that point. And then she didn't get the job, that's what happened. So I haven't heard from her since.
Yeah, I think she's still velocity, but otherwise. But she's doing really well, though. Because she lived, I guess she lived down here. She's down here.
A 3-year-old is like school 3-year-old. Yeah.
I'm trying to think.
'Cause I never met her mom, I never met the kid, I know the boyfriend. He was the one that made the referral. Strange.
On different things, and you can get your brain chemistry kind of balance, then you can.
Isn't that what all those drugs are supposed to do though, right?
The drugs balance so that the neurons are firing properly.
Okay.
Balls in here, there's not enough balls. Gloves aren't catching. Medicine creates enough balls.
I'm gonna sit because
And they prove that.
I get up, I won't
They
make
can-
it. Tapes on TV. You know, and have seeing it, and they have this great,
But, I mean, that doesn't make any sense. I mean, you know,
I would
suddenly
agree.
they reported 20 cases in one day, that makes no sense.
But I can't understand why she is. I mean, she's don't think so.
Yeah, I don't remember.
Wasn't there just the paper about it?
Yeah,
You know, but I don't know that they made an announcement to the public.
yeah, I think you're right. I don't remember anything.
So fascinating about it. Just the other day, heart rate, autonomic, some physical and subjective. But they call
site,
My wife is a chain
and it said that I've used it once.
Graduated college.
So make a note, make a note that I'm now using it again.
Never would have. She couldn't
Yeah,
concentrate. She
and
was,
I
she
need
was
it back
ADHD.
because I have one
It
more.
took a year to get her on the right medication.
Claim to be able to treat ADD.
Yeah, I was telling you, they have two about a year ago, same thing. How do you, because he said, we use this, he said, oh, well, these people don't wear corners, don't for that. Because he's just talking about spinal cord, we're talking about the brain. So I listened to this. $4,000.
Well, what does he do? Just adjust it?
And
How about
they do,
ADD?
no, and they
It's that
do.
easy, why don't you go to a chiropractor? Stop taking on your.
Well, Hollowell was talking about these cerebellar exercises
Yeah.
that he had his son doing. He went over to England, apparently, and he said nothing else had helped his son. You know, and he was doing these cerebellar exercises, and, I mean, I heard him speak last May. He was talking about that. It's like, okay.
Something that, you hate to
And
say
it worked? It worked for his son, and if Hallowell's saying it, it's like, it's not like some quack. I mean, you know. His son, I think, was a teenager. He wasn't getting any help.
The problem is, there's, no matter what you do, there's a 20 to 30% of placebo responses. And if it works, God bless it. If you want to spend the $4,000, but it's not like you get 90% of the people that are going to.
Public school do. They have let people go because of that. She's told me. Kids say,
Under 17, because everything, it has to be one child, two siblings. Yeah.
But, as a teacher, we're always concerned about.
We're also, I have one family.
You try to go the right route, but if you can't.
They're doing that.
But he's screening all of your teachers to prove that his son is.
Trying to put this all together.
That is not in the best interest of the child.
Oh, sure. So we're like, we've got a meal ticket.
Some places,
Public result.
Right.
That's for writing, we like writing. I'll tap it.
No, mine will have these like pipes. She's got new toys. She's got Jane toys.
I'm good. I'm not being here. I'll stay.
You're stuck, yeah.
Matter of fact, I told you last, we should stay overnight, so I'll have to go back over tomorrow morning.
Yeah, you should. Walter Crane was supposed to come up too. This minute, he was working too late to get up here in time, so he canceled it. And I don't know if the latest is gonna show up. She was supposed to be here too.
Well, if we have more speakers, then,
The
audience
people,
members,
yeah.
Yeah, people that it's getting to be tough to get people out of it.
They're not giving out freebies, right? That's what we're on.
That's right.
I took on communes found out that something like 35% of all the inmates in Washington, under proper medication, would have never done robberies and stuff.
Lost in space.
not gonna find it.
I remember seeing that movie several years ago.
Okay, right.
Called Awakening, and the music helped them. They have music therapy now.
I saw that movie.
They're even talking about music. They're doing neuroscience on music now, which is very fascinating to me.
Well, music can affect your entire mood the same as color does.
I find that when I get I need a collar fix every once in a while. I have to go to the card store. I have to go to the store that has collars like the towel department or something. I don't have to buy anything. I just have to go. Fabric stores. That's what I usually do. Go to the fabric stores.
You need to have your house done by one of those feng shui people.
Yeah, I can afford it.
It actually works.
I'm kind of leaning towards simplifying my decor, which is not really much of any decor right now because I'm small.
I don't think so. I don't know, we'll see. We'll see. I hope so. I'm so,
Was she sick or just not bad test?
no. Ovarian, you don't know. It's like nauseous, it's gas, it's...
Really? Oh, I didn't know
I gotta show you, I'll get you a paper on that. That is the weirdest. Changing your bowels, gas, I told you that, bloatiness, nothing that you would think was related to like a woman thing.
That sounds like it would be a lot of things.
Did you go to Cooper here?
Did I go to Cooper?
Wild.
Payment center on the wall. I need sunshine, and that's why I like gardening. So many hours. That's why the winters are so hard.
Hi.
Unfortunately. Sunday is not a day of rest anymore.
And Brian, this is like classic, right? You know, he doesn't tell me about this meeting until tonight. So now we're both gone. And he was supposed to be home like 15 minutes ago or so. He's dead deep pretty soon.
Oh, just I clipped her hair, she cleaned it up, it's growing in, but it's growing in. How long is it? Oh, good.
On your way here?
So that's, thank you for coming over. Yeah, go ahead up. Come on.
If I think of any questions, I'll speak.
Please do.
We kept the crowds in the back so you guys can, fill in the front here. I'm going to welcome all four of you to our February meeting of Adventure for Adults. We're an adult ADD support group. I take it everybody's been here before? Any? Okay. Now I guess I can cut this kind of short. You know that we meet the second Thursday of every month except for July and August. Tonight we have our physicians panel, and the way we normally work this is we pass out index cards. Does everybody have a card, or?
I have the cards.
Ed, you sure
Oh, you have.
that with such a small group?
We might, okay. Yeah, you're
Why
right.
don't you
Maybe,
just open it up, so.
maybe we should just do that, forget the regular format. Let's see. Let me just mention, next month, our meeting is March 10th. It'll be probably down in the conference room, the boardroom, down at the end of the hall. The topic is ADD and finances, and I will be the speaker on that topic. Basically, we'll be talking about how hard it is for ADD people to maintain good finances. And the word procrastination will sneak into the topic quite frequently. If you don't already have a copy of the schedule, you can pick one up in the back. And what I will do now is I will turn the meeting over to Ed Barniscus, and he will introduce our panel.
I'd like to welcome everyone this evening, and we have two physicians that we have for the panel. And the purpose of this evening's meeting is to allow you to ask questions directly to the physicians in regard to medication, ADD, or whatever. So it's kind of wide open. And what I'd like to do is have the panel introduce themselves. Joe, you want to tell the audience a little bit about who you are and what you do?
I'm a developmental behavior pediatrician who is a subspecialty of pediatrics that works with children with disabilities, and of course the most common one is ADHD. I have ADHD. I've been on medicine 40 years. I have 2 children and 2 grandchildren who have it, so the genetics are there.
I'm a family practitioner. I actually work with college students at Rutgers University, and my interest in this is that my husband has ADD and both my daughters have ADD. So I actually started lecturing on ADD, basically to spread good information around, since there's a lot of bad information out there.
And this is Mark. Mark's doing some filming. He's filming the presenters. So with that, I'd like to open it up. Does anybody have any questions for the docs in regard to medication or other?
How are you? I'd like to know how, I've been diagnosed for about 5 years, maybe 6 years, and I had gone to a neurologist, and then I didn't feel, for some reason, I felt like I was just kind of medicated, you know, and then I left and I got my family doctor to start prescribing the same medicine. We played around with the medicine a little bit, and then I've I've got online, I've come here, and trying to get help along the way to put the practices into, you know, action. But as far as finding a physician that specializes in ADD and can help along with me, like maybe playing with the medications, or not even that, like I guess I'm okay, but I don't really know. I'm just going along with my physician, and you know, I get checked like every couple of months, go see how you're doing, and just like, oh, okay. And I'm doing physical things to try to help get myself in order. I mean, it's a really big job, but I'm working on it. But I just think that I could find a medical practitioner to help give me, like, not diagnose it, but help me with the medication. I don't know how to go about, I mean, I've called a couple places.
Well, have you contacted CHAD or ADDA, the Adult ADD Association?
No, I didn't go that route.
I would go ADDA, is it ADDA.org? Yeah, it's ADDA.org, is the adult organization.
ADDA?
Yeah. And, you know, in this, there's a whole bunch of different types of specialists that take care of ADD, and that's one of the problems. There's neurologists, there's developmental pediatricians, there's adult psychiatrists, there's child psychiatrists, or there's educational consultants, there's psychologists. So there's a lot of people doing this. I think the key is to find somebody who knows a lot about it, because I remember years and years ago, I would give kids Ritalin because they were diagnosed by ADD, and you know, they'd come to me and say, okay, I'm supposed to be started on Ritalin, and I'd be giving them Ritalin twice a day, like 8 hours apart. I cringe now to think what I was doing. You have to go to somebody who knows what they're doing with the medication for sure. You really do. I would go with one of the big support groups. There's also a magazine, I don't know if you know about this, ADD Attitude. I love that magazine. I mean, I just think it's a great resource. And they have a lot of resources in that magazine. It's very reputable. They have a lot of major people that write articles for that. It's a...
And I think another
Let me add to something, because you brought up, which is a very good point, that I've been at this for 40 years, and I started, like, you know, we just started out by the seat of our pants, but it's interesting now because we spend as much time trying to tailor those who have had a lot of experience medication to the adults like yourself, trying all different things. And one of the things I'm spending more and more time is, as soon as I see a new patient and, you know, the diagnosis is confirmed and the patient decides to go that route, and I just tell them right up front, you know, you are a guinea pig for yourself, basically. And we know what kind of medications you need, but we may try 4 or 5 different medicines and combinations of medicines to get you through your entire waking day, so you're covered for your disability, our disability. Because we're not satisfied now just getting a response. We want our patients in the complete 100% remission. So I tell our patients, we can't cure you, but we're gonna try damn hard to make you as normal as we can by multiple medications at different times, depending on the different medicines we have and how they work.
Also, another issue was making sure that my insurance covered where I was going.
Oh, good luck. Good luck. Good luck with that.
I know.
I mean, the state of New Jersey has a mental health parity law that says that an insurance company cannot treat physical, biological, medical problems differently than they treat mental health problems, unless the insurance company is self-funded. If the insurance company is self-funded, they do not need to adhere to that. But if they're not, they do. New Jersey has one of the best mental health parity laws in the nation. So if you live in New Jersey, you know, and this is something a lot of people don't know, so you can really fight it if your insurance company is treating biological illnesses different than they're treating ADD. That's something that you can really go fight for. It won't cover stuff like coaching, you know, educational coaching. It just won't. You're not going to get that covered. But it certainly could cover visits to psychiatrists, medication management. It could certainly cover that kind of stuff.
You know what kind of testing they'll cover?
You know, they're all different. All the
Insurance companies.
every single insurance company is different.
And individual places take different insurances. Some might not take your insurance, and some might. You know, it's like a catch-22. You might find the right doctor or think you're going the right route, but then they don't take your insurance, so you say, well, I really can't afford it, so I don't go that route. Or
That's always a problem. That's a problem for everybody today. I mean, it seems like every patient has to change their insurance every year because their employer changes plans. And you might be going to somebody that you're really comfortable with, and your employer changes plans, so you have to change your insurance, and now they no longer participate. I mean, it's a problem for everybody with every kind of medical problem. So yes, it's a problem. You are correct. And it's very expensive. The evaluation is somewhere, I don't know, between $1,000 and $1,500 depending upon where you get it done. But that's the complete neuropsychiatric testing. For the students that I see at Rutgers, they can't afford this. You know, they don't have money for this kind of evaluation. So I do an interview. You know, I do a structured interview, and I give them a whole bunch of information to fill out, and I try to get them to get a really good friend to fill it out or their parent to fill it out. Again, good luck. I mean, sometimes that happens, sometimes it doesn't. You know, but I try and do as complete an assessment as I can, and then I'll start them on medication from there, and we'll talk about a lot of other things they can do, because they can't afford the complete evaluation. Did you have something you wanted to ask?
Yeah, I have a question. I just recently been diagnosed with ADD, probably not for the last I'd say 5 months ago I've been diagnosed with it, but previously I was seeing a nurse practitioner who never diagnosed me with that over there. She diagnosed me with anxiety and had me on different medications, where I was just getting tired and I felt like a guinea pig. I mean, I tried everything, Prozac and all that over there, and nothing seemed to help, and I think finally she got to wit's end with me. She got tired of it. So I went to a psychiatrist, and he basically came up with a diagnosis of ADD. He made me do special tests with my hands, and he said that I definitely do have it. Since I've been diagnosed with it, I no longer go see the psychiatrist because I got to pay out of my pocket for that, all that, my insurance. I had the best insurance going, but I'm military. I'd have to basically go on base, and the confidentiality issue of it I don't like. I go to a family practitioner in Walton, Dr. Euphemia. I'm not sure what her name is, but Euphemia. I'm extremely happy with her. I mean, she's you go in there for appointments. Her prices are very reasonable, but I guess my question to you is, the psychiatrist ordered me on medications, and she continued me on the same medications that he had me on.
Absolutely.
Plus, she added, right now, they have me taking Adderall. She does doctor twice a day, 20 milligrams once in the morning. Clonopin, 2 milligrams in the morning, 1 in the medication seemed to help me somewhat over there, but I still have problems with frustration levels, hostility. I doing my best to get through it. I just recently been going back to the gym over there, which you said would be the best thing for me to do over there. But in the meantime, since I've been diagnosed with this and I've been taking the medication, I lost some weight, which was good at first because I had to lose some weight anyway, but then I dropped like 17 pounds. She said I'll get it back when I started eating right. You know, all the books that you read, it says don't eat carbohydrates, eliminate the carbohydrates over there. You know, she told me that's not true. She said I can have a cup of coffee in the morning if I enjoy it, just one. She said with the carbohydrates, she says seeing at nighttime and you don't have to focus as much. She said I can stick with my pastas and my breads and all that over there, where the research I did is strictly proteins. You know, I went shopping and I was just trying to eat protein only. And one of my big concerns is gaining the weight back. I used to be a little bit more muscular, but I like to put the weight back on.
Well, first of all, it doesn't sound necessarily like you're on the right medication regimen. And when you're talking about being on 3 different medications, you know, you've got to go to the psychiatrist. You've got to go to somebody who uses these drugs all the time and has more experience with them. Because I can tell you as a family practitioner, and I have way more experience as a family practitioner than most family practitioners because I have a special interest in this. But we don't combine drugs a lot. We don't push the drug doses as high as a psychiatrist would. You know, it is worth paying out of pocket, you know, to see the psychiatrist to get on the right regimen, because then the family doctor can just write the prescriptions for you, and the psychiatrist might be willing to just see you every 3 months, every 6 months, you know, even once a year if you're seeing your own family doctor, but you got to get on the right regimen. So the first thing is it doesn't really sound like your symptoms are that well controlled on the medications that you're on.
I noticed a significant improvement.
Right.
I noticed, I think some of it has to be my fault too. You know, with the psychiatrist, I wasn't really happy with them.
Appetite suppression. And I've had people lose significant amounts of weight initially. And then I don't know what happens, but I think it's that they get used to it. I don't know it's really that they're hungry. I think it's that people just get used to eating when they're not hungry. And there are tricks that you can do. You know, you learn to eat when your medication is at the end of the dose. You don't try to eat when the medication's like full force, like 2 hours after you take your Adderall. But you might, depending upon how long your Adderall is lasting, it can last anywhere from 5 to 9 hours. So you have to figure out how long it lasts in you. And then at the end of that dosing interval, you know, maybe just when you take the second dose, that would be the time to try to eat. You know, so that's one trick. The other thing is that you have to train yourself to eat whether or not you're hungry. You know, and I tell people, if somebody put a piece of chocolate cake in front of you and you just had a big meal, would you eat it? Well, most people would. So people eat when they're not hungry. All right, so because that's something the patient always says, well, I can't eat when I'm not hungry. Of course you can. People do that all the time. You know, you just have to train yourself to do it.
One thing you ought to do, you should drink, because the problem with most of the medicine we do, they make you not hungry, but they make you dry and thirsty. And we also notice an increase in dental cavities because of our dry mouth. So one of the things you should do is drink a lot of fluids. This interesting thing is the hypocrisy of all this. During the Second World War, every pilot that flew a B-17 took amphetamines till they were toxic. And yet you can't go to the military academies and be on it. Now what do you think our pilots are using to fly the long distance flight? Provigil.
Right.
So they're hypocrites. That's the hypocrisy of most of everything we do with this disorder.
So are you trying to gain weight at this point? Or are you just trying to keep from losing more?
I like to try gaining weight now. Basically, you know, I like to put another 10, 15 pounds on by going to the gym, working out there, doing it the right way. Just don't want it to turn fat. Which I've been trying to do 4 days a week. So a little bit of aerobics, weight.
The other thing is if you're exercising, your dosage, your Adderall may decrease. If I get up in the morning at 6 o'clock, and if I don't exercise, I take my medicine at 6 o'clock. If I exercise, I don't take my medicine until 10 o'clock. So exercise stimulates your own neurotransmitters. So you may be taking before without exercise, your dosage might have been fine, but now that you're exercising, your dose may have to drop slightly.
And the problem is I have to get to work so early
No, but I'm saying, that the point is, I'm just using an example, but the point is you may have to cut back on your dosages if you're exercising a lot, because it really makes a difference. And so, you know, whether you exercise in the evening or not, in the morning, but if there's no question that exercise is the best medicine for ADHD.
What about the new drugs in Malta that just, I don't know. If
It's an antidepressant. It's an antidepressant. It's a combination antidepressant. But because of a lot of people who have ADHD have comorbidities, as a matter of fact, the majority do, you may have a comorbidity. And for instance, your anxiety can present as an attention issue. Because you're anxious, you're thinking about what you're anxious about, not focusing. Just like when you're depressed, you may have problems with attention. And if you assume it's ADHD and you give people medicine for ADHD, it ain't going to help. I mean, I'm being a little bit facetious with it. So diagnosis is important because, and you could have both. So you may need medication for anxiety and ADHD. But if you're treated, in other words, if 100 people come in with ADHD, about 3/4 of them who have a comorbidity. And so you have, and the comorbidities may present with attention. So 75% of patients we see have ADHD as their cause of their inattention. The other 25% have anxiety, depression, obsessive compulsive disorder, which presents as attentional issues. If you treat those 25% with medication for classic ADHD, it's not going to do you any good. So you have to make sure that the diagnosis is right, and if you have a comorbidity.
Your story is very common, though. I mean, it's believed that 85% of people with adult ADD are not diagnosed. And of the people who are diagnosed, the vast majority of them are undertreated. And it's not at all uncommon for somebody to have seen a variety of medical providers without being diagnosed, because up until maybe 10 years ago, we didn't even really think that there was such a thing as adult ADD. The teaching was that ADD went away in adolescence. You know, we now know that's not true, it just changes. You know, the hyperactivity, the bouncing off the wall becomes a sense of internal restlessness, and you may just be fiddling with stuff or just shaking your leg, but it changes. So it's really believed that upwards of 60% of people have symptoms that persist into adulthood. But the fact that your nurse practitioner didn't think of it doesn't surprise me in the least. Not at all.
It's interesting. 40 years ago, I was at Fort Benning, Georgia, and the first articles came out on ADHD, and I was a medical officer, and I found out that I had ADHD. It took me 2 years to find somebody to confirm it because it was so new. And you think I could get any medication in the Army? No way. No way.
Cymbalta is just the newest guy on the block, you know, in a group of antidepressants. It's no better, it's no worse. You know, it's like any of the other ones. It may work for you where other ones didn't, but it's not necessarily any better. It's just new.
Thanks.
Could you discuss the impact of caffeine on stimulants?
I think the thing is, anytime I see a new patient, I just tell them, no caffeine until we get your dosage to the maximum. Because
What does that do to
caffeine's a stimulant. Nicotine's a stimulant. Nicotine and caffeine are stimulants. So if you're taking stimulant, another type of stimulant, you can't. It's hard to get the dosage of the medication because you don't know how much of it's medication and how much is the caffeine. Now, for instance, if I'm down at the beach and I don't take my medicine, and I want to sit, and my attention span is 25 minutes, since 30, 40 years ago when I was diagnosed without medicine, I'll take a double espresso, I can go an hour and 10 minutes. So caffeine's a wonderful stimulant, but it doesn't last but a couple of hours. And cigarette smoke, I'm not saying suggest you take cigarette smoke, but cigarette smoke even works faster. It works within 10 to 15 minutes, but only lasts half an hour. So we try to take people off of everything that can mimic, and medications for colds, and the medications that dry your nose up can confuse the dosage. And so until we get the dosage completely figured out to the maximum, then you can take coffee if you want to, or if you like your coffee. So it really is the most common drug used in the world today is what? Caffeine. Caffeine is the most common drug used in the world today. Children 4 and 5 years old, you'd be surprised the consumption of children are using caffeine. And it's interesting, the Barniskis know 25 years ago when we first started, we only had Ritalin. One time, we were giving kids cups of coffee every 3 to 4 hours, right? Remember that? So caffeine's a wonderful stimulant, but it's in and out too fast. And see, the problem with the short-acting medications is that it's a roller coaster, you know. And again, don't forget, if you ask the teacher when it's up here, and the teacher says, it's working great. You ask the teacher here, it says not working. And the point is, just because we say the medicine lasts 2 to 3 to 4 hours, and I have patients only last an hour and a half and 2 hours. No two patients metabolize the drugs the same. And I don't, matter of fact, as you know, I don't even like to use the term drug. I use replacement medications. But these replacement medications, every one of us is a different chemical factory, and we metabolize medications differently. And you have to find out how fast they kick in and how long they persist. And then you can learn to dovetail medications so to get coverage for the whole day or however long you want it. So it's an art. It's an science and it's an art.
My question with the caffeine is, I mean, I'm going to use myself because that's the experience I have with it. I will have 2 cups of coffee of regular caffeine in the morning, and I don't have coffee later in the day because I personally feel that if I have coffee after 12 or something, then it hits me way later, where I'm just awake.
Now that's the difference. There's a difference between the ability to help you focus is short term, but the ability to affect your sleep is much longer. You understand?
But I'm trying to understand because I'm trying to see
that's what I'm saying. In other words,
has an effect. I have 2 cups of coffee every day,
Sure.
and maybe I won't finish the second or cup or whatever. But say just 2 cups of coffee, not because I think that it's gonna. I mean, I like the taste of real coffee in the morning. Have the coffee, and I don't feel I get awake by it or stimulated by it. The only way that I know that I won't drink it later, because I'll lay in bed at night and just feel like I'm awake.
When do you
But
take
it's
your medication in
in reference to that,
sure.
like with the coffee, after the coffee, like, you know, I don't see any issues that I have with it because I don't know what I'm looking for.
Well, the biggest thing is that, you know, caffeine's a drug. So if you're going to take, first of all, when you start the medication, I agree, I try to get the patients to stop all caffeine because the Barniscas, you know, really believe that caffeine shortens the duration of the action of the stimulant. And so it's not just that it's another stimulant, but that it will shorten the duration of the stimulant that you're taking. But most
above that, so that could be,
of over and above that.
It's not that I'm getting stimulated from the coffee, it could be that I'm getting negative results from my medication.
I think you need to be, you have to find your ideal regimen. And once you find your ideal regimen, then if you have to have your cup of coffee in the morning, what I tell patients is it always has to be at exactly the same time in relation to when you're taking the medication, and it always has to be the same amount of caffeine. You have to standardize it like anything else. You can't like one day have 3 cups of coffee and the next day have a half. You can't have 1.5 cups and then the next day have 2.5. It has to be the same amount of caffeine. And you have to take your medication whenever you're going to take it, with it a half hour after it, a half hour before, but it has to be the same because it's another drug. So it's just a confounding factor. You know, so what I tell patients is I'm not saying you're never going to be able to have coffee again because most patients, like, you know, just get hysterical if you say that. What I say is let's get you on the right medication regimen and then, you know, have your cup of coffee in the morning, but we're going to standardize it. And that seems to work.
And again, for the stimulants to help you focus, it works right away within the first half hour, first 2 hours. But the effect on your ability to get a restful, affects your sleep, lasts for a lot longer than that. Just like Benadryl, you can take Benadryl at nighttime, and you're sleepy. In the morning, you wake up, you're fine, but it still affects you cognitively. It takes you twice as long to do mental problems, even though you don't even know you think the effect's gone. So the effect on sleep hangs around a lot longer than the effect on it, where it helps you is a stimulant, if you're going to use it as a stimulant.
One of the trickiest parts of this is finding out how long the medication lasts for a particular person. Because you take a medication like Adderall, and I've had patients who swear to me it's only lasting 2 hours. And I have other patients where it lasts 9 hours. Well, that's a huge difference. So it's really key to try and find how long the medication is lasting. And it's most helpful to do that when you first start the medication because you're most likely to feel it wear off when you first start the medication. It's a phenomenon called rebound, when the medication wears off. You may just feel yucky, or you just may feel tired all of a sudden, or you may get more hyperactive, but you'll feel that way for like 30 to 45 minutes as the medication is wearing off. That's like a golden period as far as I'm concerned, to try and catch that rebound initially when somebody starts the medication. And quite frankly, the person themselves might not be the best person to know when that's happening. Usually it's somebody else who can observe the person and tell them when the medication's wearing off. So it's very helpful to enlist the aid of somebody who knows you well. I mean, if you have a spouse, that's fine, but if you're in another relationship or if there's somebody around you who knows you really well, you know, what I tell my students is have somebody start watching you, you know, X number of hours after you start taking the medication, and then keep paying attention to you and tell you when they think it's wearing off. You know, and we'll compare the two, and we'll see how close they are to each other.
Another thing you can do, and you can do with yourself, and you can do with your children, I have little diary cards, and the same similar thing you do, and it says time the medicine is taken, the time the effect begins, the time the effect stops. And what I'll do is, and obviously it depends. You have to obviously how old the child is can understand. But I'll ask a kid, tell me how long you can sit in your most dull, boring class you had. And they'll think about it. And I'll say, how long are your classes in school? And they'll say 45 minutes in general. Why did they pick 45 minutes? Anybody know? Why did they pick 45 minutes?
There was a reason?
Yeah, sure there was. That's the normal attention span of a person probably without ADHD. So what I say is, and I'll say to a teenager, I'll say, all right, tell me when you start daydreaming, look at the clock in your most dull, boring class. Is it 20 minutes after the class started, 30 minutes, 45 minutes? And so and as we increase the dosage, we can get it up to these kids are focusing 45 minutes like everybody else is. But you have to push the medication. Now, if a child says, the converse of that is, if you have a child, say there's 30 kids in the class, they all have the same IQ, okay? And the class is 45 minutes long. And a child who has attention deficit, we'll say it's 30 minutes. So you start him on medicine, and he gets him up to 40 minutes, and the parents are happy as clams. But still 5 minutes, he's not learning, correct? Or your child's not learning compared to everybody else. So if we don't get your dosage perfect, you are handicapping yourself versus the rest of the world, if you will. I'm being a little facetious here. Do you understand? So you have to push the medicine, and you can, and people like yourself can sit there and read the most dull, boring book you want, and have your spouse say, wait to see you start daydreaming. They can say, hey, you sat still for 15 minutes. You started your medicine, now it's 20. And as we increase the dosage, you should be able to go longer and longer and longer. We cannot cure ADHD, but we can normalize it if we individualize, titrate these medications. Does that make sense? So it really is, it's an art, and we have to work with. And I tell patients right off the bat when they come in, you know, don't think I don't know what I'm doing because we're changing medicines and jotting down things. That's part of how we manage it, because I've had patients say, you don't know what you're doing because you're jumping all over the place. And so I just tell them ahead of time, you are an individual chemical factory than anybody else here, and we have to match your chemical factory versus what we're trying to do to get the maximum, to let you work up to your God-given ability. If you don't, it has nothing to do with your IQ, it's your attention span, plus your IQ is how well you can learn.
No other questions?
Well, can I ask a question about this? Are you familiar with it?
No.
The brain room talks about the brain chemistries and balancing all of them.
Okay.
Dopamine, acetylcholine, GABA, and serotonin.
Mm-hmm.
Those kinds of things. It's talking about the beam scan in the back. I just bought this place. We talked about scanning of the brain, finding out what's working and what's not working. Those kinds of.
They're not doing that. That's not something That's research right now. That's not done clinically. You know, they have done that kind of scanning. There's a guy in California, A.M.A.R.C, who does SPECT scan. He's been doing that for a while to look at changes in the brain with different types of ADD. And then there's people who are doing functional MRIs and PET scanning, but that's all still research. You can't get that done right now unless you're enrolled in a research trial. You know, I think we're moving towards that, and that will be extremely helpful.
Specs not mainstream yet either?
Not for this.
How about the QEEG isn't either?
It's interesting, though, I just saw they're in the psychiatry literature, they're now coming out with a blood test that the primary care physicians can do to see how well you're going to respond to a certain antidepressant depending on your genotype. So these research projects are getting closer and closer and closer to, but like agree, these are all research things you're talking about.
Can't sign up, huh?
Call that NIH.
Because my girlfriend, she's a nurse practitioner, she sent me the research on the genotype things, and she says, why don't you look into this?
Well, if you have ADD, it's thought to mainly be a problem with dopamine. So, and the stimulants work on dopamine. You know, so you're dopamine and norepinephrine. So those are the two neurotransmitters you're playing with. So that's what you want to start out with. You know, serotonin is more in the antidepressants. You know, and serotonin, you know, that's not involved with the ADD.
Well, he kind of types your personality according to what your strongest brain chemistry is, so it was just, you know, are you treating the right thing?
You know, I read this book, by A.M.A.R.C about the different types, the 6 subtypes of ADD, and it's really fascinating, and I think it's probably true. The problem is, you know, we don't have that information available to us. We don't have a blood test. If we had a blood test for ADD and we could do an MRI and show, we'd have better coverage for this. Because really, what's the difference between Alzheimer's and Parkinson's? I mean, they're neurologic diseases, so they get covered by insurance, but ADD is a mental health problem. Migraine is a neurologic problem, so that gets covered by insurance, but depression is a mental health problem. It's garbage. It's all the same thing. It's just different neurotransmitter problems. And I remember being at a conference for migraines with a whole bunch of neurologists and telling them that basically in the future, everything is going to be, you know, a neurologic problem because it's all just brain chemistry problems. They were horrified. One older neurologist said, "Thank God I'll be retired by then." I swear to God.
Well, that's his whole point, is we're treating symptoms. We're treating medical symptoms instead of brain chemistry, which
Exactly.
is creating all of the symptoms. Right?
Exactly.
But there's no way to measure your brain. You must stick a needle in a specific area. It's that specific. It's not like you can do a blood test and your blood test shows you.
So the MRIs don't pick up on that.
Oh yeah, they will pick up on it, but the point is, it is so specific. These areas in the brain are so specific that you have to do sampling of the blood and the spinal fluid right there at that spot to be able to tell. So we're kind of flying by the seat of our pants, trying to match symptoms with treatments. That's the best we have.
This is the cutting edge. I mean, I read in 1980 about the antioxidants and all these other kinds of things, and it didn't come out for 20 years. 20 years it took the doctors to say you need to be taking these things, and then free radicals.
It takes a long time to do these research trials. You know, and right now, it'd be nice if we had a blood test, you know, to measure your cholesterol and decide how much Lipitor you should be on. You know, for your ADD, if we could measure your dopamine level, you know, and find out how much, you know, Ritalin you should be on. Oh my God, you know, that would make our job so much easier, because right now it's a crapshoot. I mean, you start with a stimulant, and then you don't know how long it's going to last in the person, number one. You don't know what the right dose is, and you don't know if it's the right stimulant. And you don't even know if this person can tolerate stimulants, you know. And then when you're talking about the antidepressants, that's a crapshoot too, you know. Maybe Prozac will work, maybe Zoloft will work, maybe it's Alexa, maybe it's Lexapro, maybe it's Cymbalta, we don't know. We really have no way of knowing. They're all slightly different. They're not identical. They are different because one will work in a person and another one won't, so we know they're different. And the same thing with the stimulants. Adderall might work, but Ritalin won't. They're not exactly the same. We don't know. And it would be extremely helpful if we did know, obviously. You know, because by the time the patient comes to us, when I see these students, they're about to fail out of college. I mean, they're on academic probation. They're about out the door. So we're in a desperate situation here. You know, and it'd be very helpful if I knew immediately what drug to put them on, what dose, what interval, you know, to sort of save their careers. It's very difficult.
It's interesting, as I said, I've been in practice 40 years, and there are no medications in there's only maybe one or two medicines in all of medicine that we have had more experience than we've had with the amphetamines and the methylphenidates. The amphetamines were compounded in 1888, their first compound. We've been using them since 1927. Methylphenidate was compounded in 1957, and then we started using it in the 60s. Now, only aspirin, digitalis are medicines we have any more experience. We have the safest, the most experienced medications of all of medicine, and people are still hesitant to play. Well, I don't want, but so you understand? It's really depressing. How people are using Cymbalta? It's only been out, not even out 2 months.
Which company is that?
Huh?
Which company is that?
Lily. How long do you think Prozac has been out? 1990.
87.
Yeah, but I mean, we started using it in 1990. So how much experience have we had? And yet we're scared to death. People are worried about it. And the other thing is, there are no medications in medicine that you can predict 70% or better results with a medication. Do you know what the chances of you, when you use any antidepressant, are hitting it the first time? What do you think? 50%, 6%, 70%, 80%? What do you think? 45%. So again, we try to match what looks like it's going to work with you, knowing that it may take 3 or 4 to get there. So, but yet the amphetamines and the stimulants, we start with 75% or better, and you to use the one or the other, you're talking 95%, and they work faster than any other medicine we know, and they're out of your system at certain times. So you can work with them knowing it's not going to hang around for 3 or 4 weeks like Prozac will hang around 3 or 4 weeks if you take a pill. So we have to start thinking of how great these medications are and not be afraid of them. And again, I'm saying they're not saying they're not. There's always a side effect. We have people who die from taking aspirin every once in a while. It's going to happen. I don't care. But the point is they're the safest, fastest acting, most efficacious medications I know of. And it's one of the most rewarding parts of my practice. I get a kick every day giving somebody medication, and it changes their lives. Adults, they're going to get divorced because their husband doesn't listen to them. He's doing whatever It's amazing. It really is amazing. It can change people's lives. It really can. There's not many medicines that can do that.
I have a question. A lot of the physicians have a tendency to put the adults, the children, on long-acting stimulants, or the new one, Strattera, which is not a stimulant, because again, they don't have to take it so frequently. What do you feel about that as far as taking, having them start immediately on long-acting medication? And what about Strattera?
The nice thing about the really short-acting medications is that you can tell when it's wearing off, and plus the variation in how long it lasts is less. So if you're talking about like Ritalin, it's like, could be, most of people it's 3 to 3.5 hours. It could be, 2 hours, 4 hours, but it's not like the Adderall where it could be 3 to 9 hours, or, the Adderall XR, which is even greater variability. So what's nice about the short-acting drugs, and the wear-off is really abrupt. When the Ritalin or the Focalin wears off, boy, boom, it goes down. So people really feel that. Well, they don't like the way it feels, and what I tell people is, I'm not going to make you do this over and over and over again. I just want to know how long it lasts so we know when to start the next dose. But then there's the inconvenience factor of having to pop a pill, every 3.5 to 4 hours. So you have to get a watch with a timer, or a lot of the college kids plug it into their cell phone or their PDAs. I mean, there are ways to get around that. So I usually will try to start, I honestly have to say, I've tried to start with the short-acting agents because you can get the dosing interval really correct, but the college students, they can't do that. They can't do multiple dosing a day. So I end up doing the long-acting drugs, but the problem is you don't know how long they're lasting. That's the biggest problem. You take something like Adderall XR, and the wear-off is much more gradual. Now, the good thing about that is the wear-off is much more gradual, so you don't get that falling off the cliff feeling. But the bad part is, since it's much more gradual, people can't really tell when it's wearing off. So you don't really know when they're not being covered anymore.
Strattera is a 24-hour-a-day medication. And to help you understand, it's really an antidepressant and stimulant hybrid. It was actually brought out as a antidepressant to work on norepinephrine and serotonin, because we know now that medications, if you have depression, medications that work on serotonin and norepinephrine work better than the ones that work on serotonin. So this medication was brought out 9 or 10 years ago as an antidepressant, but it did not make muster as an antidepressant. But we found out that it worked very well on norepinephrine and also dopamine too. So we revived it off the scrap heap, literally. And said, wow, if we've got a medication that works on norepinephrine, let's see how it works in ADHD, and that's how the trials got started. And so but it's an antidepressant. Antidepressants take 4 to 6 weeks to work. It takes 4 to 6 weeks to work. You can't make it work any faster. I don't care what you do. So the point is, people don't want, we want instant everything, sex, whatever it is these days. So people, but the point is, it's better medication for a couple of things. The advantages are, once you get, we call it a steady state level. See, the amphetamines, they'll never get what we call a steady state because it's in and out. But these medications, like the antidepressants, 3 or 4 weeks, they get a steady state. So the nice thing is, if you're on Strattera and you miss a whole day, it still works. Still working. You miss your Adderall, you know darn well you've forgotten it, right? So that's an advantage, but it takes a long time to work. Now, basically, it does not work as well for attention as the stimulants. So most of us now are using them in combinations. Now, okay, and that's another aspect we can talk about. But the thing about these long-acting medications is ADHD is a genetic lifetime disorder. There's very few people that are going to come off of it once they're on it. You may not have the full-blown syndrome, but you're going to have symptoms that are maybe enough that you still will need medication. So you don't take your high blood pressure for 8 hours or 4 hours. You don't take your antidepressant. You don't take your Lipitor. You take medicine for 24 hours because it's a 24-hour, 365, 80-year disorder. But we never had medicines that lasted that long. So now we are starting to get medications that last 24 hours, so we're starting to take advantage of it. But again, they're first generation. They may not, 10 years, they may have ones that work perfect. But in general, they don't work as well for attention. I used to take 45 milligrams of Adderall XR. I now take Strattera and 5 milligrams of Adderall XR. On the weekends, I don't take any Adderall. So the nice thing is by using them in combination, especially in the adolescents, because I will not let my kids drive unless they're on medication. Because we know if you have ADHD, you don't take your medicine is not on board when you're driving, you have 5 times auto accidents, driving convictions, speeding tickets. Now, if you take your medicine, you're still going to have accidents, but no more than the average person, basically. Everybody understands that? You also have 3 times substance abuse as you go into adulthood, adolescent adulthood. So actually, by taking the medications, they are protective. So if we love to have medicines on board 24 hours a day, we didn't have those before. Well, we had Wellbutrin and Effexor, but so now Strattera is on board 24 hours. So now I can convince my parents, if their kids are driving, they say, oh yeah, I want my kid on that medicine. It may not work, it doesn't work for everybody like everything, but they understand the thought process there. So if the kid forgets it, he's at college, he's driving at 3 in the morning, you know, if you took your Adderall at 7 in the morning, 3 in the evening, and the kid's driving at 3 in the morning, you're gonna be on board. So it's a safety, security thing. But again, it does not work sometimes as well as the amphetamines or the methylphenidates for attention. So about 2/3 of my patients are on Strattera, if you choose to go that route, and a dose of their stimulants. And again, like I said, I used to take 45. So what I did, I took 45 milligrams of Strattera, 45 milligrams of Adderall. I started Strattera, and after 3 or 4 weeks, I started decreasing my dosage of Adderall until I came off of it, and I was off of it for a couple of weeks, and I noticed my wife, my staff, they can tell you, and they said, and so now I take 5 milligrams, and that's back where I used to take 45. But on weekends, if I don't need it, I'm down at the beach, and I'm playing, and coursing around, you don't need it. Now, again, so the other thing is that people don't realize that ADHD is a cross-pervasive disorder that affects you in every aspect of your life. I have professional athletes. One plays starting center field for the Texas Rangers, 2 play for your Wings, because they're not in school, but they know it helps them focus on their athlete, that's a sport. And again, if you know yourself, if you don't take your medicine, your wife's got a honey-do list for 3 things, you do one and get distracted and never do the next 2. Try and do, if you have ADHD, try and do your checkbook or your tax account if you've been on medicine and you'd stop. So you'll find, but these are the subtle aspects that people don't, so you understand, you should be on a medicine 24 hours a day. If possible, if you can't, you should be on medicine. Most people should be through their waking day.
I want to give you a counterpoint, because I don't like Strattera. First of all, I totally understand what he's saying, but I have not had great success with Strattera, number 1. Number 2, there's not a lot of head-to-head studies of Strattera versus methylphenidate. Number 3, the original studies that I saw with Strattera were done in children. It actually works better in children than it works in adults. It does work in adults, but it works better in children. And the studies were done with people who did not have comorbidities. The adults that were studied did not have comorbidities, meaning anxiety, depression, substance abuse. But we know that 80% of adults with ADD have something else going on. So we actually don't know that Strattera works in those people. And the psychiatrists that I work with use a lot of Strattera, but I will tell you that a lot of people have a lot of side effects, number 1. Number 2, it's a brand new drug. This is a brand new drug. Let's not underestimate the fact that in 5 years we could take it off the market because too many people have died of liver failure. I would not lightly go on something that's a brand new drug that hasn't been out for at least 5 years unless there's a real compelling reason to do that. Now you take something like Viagra, where 60 million people have used it. If something terrible is going to happen, you're going to find out pretty quickly. But you take a drug like Strattera, where very few people are going to take that. It's going to take a while before you potentially find that there's a problem with that drug. So I'm not crazy about Strattera. And the medical letter, which is very non-biased, it's like the Consumer Reports of Drugs, came out against Strattera. It evaluated it once when it came out, and it just came out again as a second evaluation, and basically said it's been very disappointing. That the side effect profile reported in the PDR, 8.5%, is like way underestimated. That many more people than that have side effects and stop it. So it's just like, I want to give you a different view, It'd
be interesting and again, I agree with you. We don't have the experience, but we have over 3 million patients on it now. We've had using it for over 9 years. And again, it doesn't work for everybody, but it's the forerunner of the medications that are coming. Matter of fact, there's a methylphenidate patch coming out that's going to last 24 hours. There's a clonidine patch that's going to last 24 hours. There's Focal in LA is coming out. So everybody is going to try and get longer and longer duration medications. I used it, and again, but I apologize, I mean to say, but you have to understand that this medication is a hybrid. So to say it doesn't work against anxiety, and it actually works against anxiety.
No, I didn't say it doesn't work.
No,
what I said was it wasn't studied in people with comorbidities.
But now it is. Matter of fact, the studies we have studies now that, and again, I'm not defending. I'm just saying that obviously we need to study these. And nothing's like time. You have to have time. But again, this article came out that some people had liver problems. 2 out of 2 million had liver problems. Did anybody hear about the literature came out? If I do clinical research in our office, any medication that you take by mouth goes through your liver, and we do liver function studies. Okay? 10% of any medication you will do will affect your liver function testing. We have people that have to stop aspirin. You know that, right? Because it affects your liver. And how many billions of people take aspirin? So any medication will make your liver function tests be slightly abnormal. And again, so, again, I'm not saying it's
The liver's
safe.
an example, but it's more like the thing with Vioxx. I mean, sometimes you just don't know till a drug's been out for a while. And my feeling about it was, I had one daughter who developed very severe tics after starting Ritalin, and she couldn't take a stimulant. And Strattera came out, and one of the reasons to use Strattera would be somebody who can't tolerate a stimulant. And I wouldn't put her on it because it was a brand new drug, you know? And she wasn't like falling apart. She was still doing pretty well in school. She's a really bright kid. I'm not gonna put her on a brand new medication. So, I mean, a lot depends on, you know, what risk you're willing to take, who you're taking it for. You know, I think a lot of family practitioners have jumped on the Strattera bandwagon because it's easy. You can write a 3-month prescription. You don't have to, you know, refill it every 30 days, so it's easier to do. But I don't think it's the best way to go. I think there's a 70% response rate with stimulants. You should start with stimulants first, unless somebody can't tolerate it, unless there's a reason why they can't take stimulants. And there aren't that many true contraindications to stimulants. It's psychosis, and I think there's one other one. I mean, virtually everybody can take them.
The interesting thing, and again, I use every medicine out there in all kinds of combinations. As a matter of fact, I take Provigil too. So I try everything that to see what works. But these medications
you know, he does that for his patients, so he can figure out what's good.
Well, don't forget, 40 years ago, there was not a study. I would try it myself. I try it my kids, and we would try it and listen to you guys and see how it helped. We learned trial and error. That's the way we learn. And but again, this is not a new medicine. It's been out 8 full years. We almost have 3 million patients. It's not something like.
I don't think you're going to die. I'm just saying, you know,
right.
Something to think about.
No, but
you know,
the point is, it doesn't
really
work. It doesn't
long
work for
time.
everybody, right?
I'm sorry, we have to wrap up because of the time. So I just wanted to thank everyone for coming out this evening. I want to thank Dr. Salazzi and Dr. Hill. And 10 years ago, we started the support group. And 10 years ago, ADD was controversial. 10 years ago, medications were controversial, and they still remain that way today. So there's been a lot of progress with ADD, a lot of scientific knowledge has been contributed, there's been great gains in the treatment of ADD and understanding of ADD, but we still, as you can tell, have a long way to go. So again, I want to thank you all very much, and we'll see you hopefully next month. Thank you. Thank you very much.
We have to push these. Matter of fact, the COMAC study, the START study, only treated the patients for 3 weeks.
But we a lot of patients from here. We have patients from Pennsylvania, Maryland, Delaware.
Where in Delaware are you?
We're in Wilmington.
In Wilmington?
See,
45 minutes. My wife went to law school in Wilmington.
yeah, well, that.
I feel for what you were doing.
Well, I've been around 40 years, and even more, I'll have to learn something. But the point is, everything I've done, I've tried on myself first. Every medicine, every antidepressant, I've tried. Zyprexa, risperidone, Abilify on myself because I want to make sure I know what to do.
What do you start a patient on? What is the threshold, the entry level drug that you start with ADD?
Either methylphenidate or amphetamines. I usually start with Adderall XR. I like the long-actings and Concerta, but if a parent is a little squeamish, Ritalin, because. But if parents are a little squeamish, I'll start them on a short-acting one so they can see how it works, and then they know it's not going to be hanging around.
It's her child. She didn't want to, you know, put it on her child because it's new.
Yeah.
Then it's her child.
Right, and that's
It's more of a
definitely.
risk with her child.
My mother can't. tolerate anesthesia or even pain meds. She got to take a Tylenol